So picking back up on murmurs in cardiovascular disorders, let's talk a little bit about what the pathologic murmur signs are, okay? So a murmur in a child with a syndrome associated with congenital heart disease, that could be a pathologic murmur. For an example, Down syndrome or trisomy 21. A diastolic murmur, okay? Any systolic murmur that is associated with a thrill. Pansystolic murmurs, okay, so pansystolic means it lasts all the way through S1 and S2. Continuous murmurs that cannot be suppressed, okay, so meaning no matter where you listen, it just seems to seem exactly the same with how you're listening to it. If you have a systolic click or an opening snap, some of these things you're going to be like, what? What does that even mean? What does that even mean when I'm listening to it? One of the things I like to tell students is if it's something you're listening to and it just doesn't sound right to you, not necessarily a murmur, so when you hear more murmurs, the more murmurs you hear, you're going to say, okay, that is a murmur. But if something just doesn't sound right and it doesn't feel right when you're listening to it, then it's probably not right, okay? Doesn't necessarily mean that it's a major problem, but if something sounds wrong, you're hearing an extra heart sound or you're hearing a funky sound between the S1 and S2 that just doesn't sound right to you. You're hearing gallops, okay? If it sounds like a horse is running when you're listening to that child's heart, that would be a gallop. So a brum, 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 where you just should be hearing a lub-dub, lub-dub, lub-dub. Instead, you're hearing a ba-da-la-bum, 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 okay? Or if a murmur is not positional, okay? So it doesn't change sound depending on whatever position that the child is in. Grade 3 to 4 or higher are definitely going to be something that you're going to consider as a pathologic or concerning murmur. The other thing that you want to think about is what is the harsh quality, okay? So if it sounds just really harsh when you're listening to it, that isn't normal, okay? So that isn't something that you would be considered as an innocent murmur. It's going to be something that you would find as a non-innocent or pathologic, okay? So a thrill, okay, so some of you may or may not know what a cardiac thrill is, or systolic murmur associated with a thrill. A thrill is felt from light palpation over the chest wall, okay? So it's a vibratory sensation felt on the skin overlying an area of turbulence, okay? So if you're hearing a loud heart murmur, and when you barely just touch the chest wall, you can feel a thrill, that is something that is considered pathologic and definitely concerning for you, okay? Now, I wanted to let you listen to some heart murmurs. Now, some of you may or may not have heard lots of heart murmurs. There are tons of wonderful websites out there for you to listen to heart murmurs, but I really want to make sure you have a good opportunity to hear some of the ones that I think are excellent learning opportunities, okay? Now, a systolic murmur is a murmur that occurs between S1 and S2. Okay, so lub-dub, lub-dub. We have S1, S2, S1, S2. A diastolic murmur or a pathologic murmur is going to be a murmur that occurs between S2 and S1. So as the heart is going through its cycle, a murmur that occurs after S2 and to that next S1 is a diastolic murmur and it will always be pathologic. You will, I am almost positive, recognize it when you listen to it. Even if you don't know exactly what it's caused by, it doesn't sound right. It doesn't sound like the normal boom, 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 boom. So I'm going to play some cardiac sounds for you, some murmurs, and I'm going to kind of gently tell you what you are listening to. Okay, because there's different types of systolic ejection murmurs, but systolic ejection murmurs are usually more of them are innocent than the others. Obviously, diastolic murmurs, like I said, are always pathologic. Okay, so this first sound you're going to hear is a systolic ejection murmur, meaning it occurs between S1 and S2. So is the second one. That's another systolic ejection murmur. So is this. Systolic ejection, occurring between S1 and S2. Listen here. This is diastolic. Can you hear the difference? Let's try that again. I'm going to play it again. Systolic ejection, systolic ejection, systolic ejection, this is diastolic. Can you tell the difference there? Almost that harsh pound after S1, so it's boom, pff, boom, pff, boom, pff. It's different from a murmur that occurs as a systolic ejection, where it's, occurring between S1 and S2, and it is just sounds less harsh after that S1 and S2 occurs. So I'm going to play it one more time. Let's see here. Systolic, still systolic, occurring between S1 and S2. Listen very closely at the difference between this and this. That's diastolic. Okay. So again, it's important for you to understand where a murmur occurs, because that's really how you're going to be deciding what it is that you are doing. A systolic ejection murmur is usually, if it is occurring between a 1 to 3 in grade, it's usually going to be innocent. Any diastolic murmur is pathologic. If you're hearing that murmur that sounds like it's between S2 and S1, that is a problem. All right, let's move on here. So, murmur tips. You want to make sure you're diagnosing the grade. You want to document the timing. You're going to document the location. You're going to document whether or not it radiates. You're going to document the quality. Is it harsh or is it musical? You're going to document the duration. Where does it occur is important, but you need to know how long it occurs for. Okay? And then the pitch. Is it low, middle, or high pitch? If you're going to be documenting a murmur, please, as I stated earlier, do not just document murmur present. That does nothing for people who are trying to help you diagnose a child. It does nothing for people who follow after you. It also does nothing for yourself. If you see that child again and you're trying to assess where that murmur is in, where it was present and heard best last time versus where it was present and heard best this time. And if you refer to a cardiologist and you write murmur present in your documentation, they are going to be upset and roll their eyes. They need to know more about that murmur and what you heard when you listened to it. Okay? All right. So let's move on to respiratory disorders. Okay? So this is your normal presence of a respiratory system here. I'm not going to go over major details of what these things are. You know what bronchus is. You know what bronchioles are, I hope. Okay? And you know the trachea, the ribs, the lung, etc. Now, upper respiratory disorders are so common in children. Okay? The common cold, a viral URI, acute rhinosinusitis. Okay? That is usually, if it's acute rhinosinusitis, okay, that's what you would think of as a sinus infection. But in young kids, it's really rhinosinusitis because they do not have the types of sinuses yet that the rest of older kids, okay, have. So they don't have their frontal sinuses yet until they're over age about 7 and 8 years old. So I always get so frustrated when I see people diagnose acute frontal and maxillary sinusitis in a kid who's 2 because those sinuses don't even exist yet, okay? And that's why we use a diagnosis of acute rhinosinusitis, and you can still use sinusitis, but you really need to think about the age of the child that you are diagnosing that in. Subacute rhinosinusitis, okay? Basically the same as your acute sinusitis, but it's present for at least 30 days, okay, and persistent for 30 days. Next, chronic on recurrent rhinosinusitis. This sounds so confusing, and you're like, what? What does that even mean? Okay, so what that means is that the kid has got it recurrent, greater than 10 to 28 days, but they have been symptom-free for at least 10 days between bouts of over 84 days. So basically, they have chronic sinus infections, but they have periods of getting better in between their periods of being acutely ill. Okay? Now, most sinus infections can be managed with amoxicillin. All right, we're not going to have to break out big guns of medications for young children who are antibiotic shy. You know, they haven't received a lot of antibiotics. You can give them amoxicillin. And please do, and make sure that they're taking the full amount of amoxicillin. All right? And then for your kiddos who have subacute rhinosinusitis, or of course chronic recurrent rhinosinusitis, you're going to go a little bit stronger with them. You're going to give them some Augmentin. You're going to add that clavulanic acid. You may give them Zithromax, and you may consider staph coverage for chronic rhinosinusitis. For kids who are exposed to staph, who may have a history of staph, even a history of MRSA, etc. Okay? Now, these last two are a lot less common than your first two. The most common is your common cold. Okay? And the number one most important thing you must know about manage of a common cold is that it does not require antibiotics. Please do not hand amoxicillin or any other antibiotic to a kid who comes in to see you with 7 days of runny nose congestion. Even if the mom says, oh no, his drainage is yellow-green. Oh, well, he had fever 4 days ago, and that fever was up to 102. He is so congested, and he's been congested for 7 days now, and usually we get an antibiotic if he's had congestion this long. No, your prudent provider is going to tell any caregiver, I'm sorry, that if you have less than or equal to 10 days of cold symptoms, you're getting no antibiotics, okay? And for me, I'll be honest with you, it depends on the literature and the evidence that you're reading. Some evidence even says 14 days. And for me, it's usually around that 14-day mark that I will not give antibiotics until they've reached that 14 days, okay? So, and, you know, you can, however, though, give parents a way to feel better. So if you have a kid who comes in and they are at that 7 or 8 day mark of URI symptoms, you can do what's called a WASP prescription, and I do this all the time. Here, Mr. Smith, I'm going to give you an antibiotic for little Josie Sue for some amoxicillin, and I'm going to date it 5 days from now. If she has still got runny nose, congestion, and coughing and green snot coming out, then please start this amoxicillin. You know, there's actually been really good evidence and literature and research studies done on WASP prescriptions for ears and other types of infections. And it has shown that parents are not only happy with receiving those WASP prescriptions, and they, they try to challenge providers less, but they don't fill them. 75% of the time they don't fill those prescriptions, but they feel better walking out the door knowing that they have it in case they need it. Okay, so consider the use of those wait-and-see antibiotics or WASP prescriptions in your practice. It really is essential, and it can change your practice, I promise. All right, so next, pharyngitis and tonsillitis. Did you know that 98% of pharyngitis in kids is from a virus? 98%. Okay? So what does that tell you? It tells you that not every kid with sore throat is going to have strep. Okay? Not every kid with sore throat needs cephalexin or amoxicillin or Suprax or Augmentin or, all of the other antibiotics that we prescribe for, possible strep. It is not necessarily strep just because they come in with a sore throat. All right? So you need to make sure that you're understanding that viral pharyngitis is the most common type of pharyngitis in both kids and adults. Usually a sore throat is from a virus. okay? And a lot of times kids who have upper respiratory symptoms have sore throat because of postnasal drip. So think about it. If you have runny nose and you have congestion and you have cough and you go to sleep and you lay down and all of that drainage leaks from your sinuses and your nasal area down the back of your throat because it's all connected, what's going to happen to you in the morning? Oh, horrible sore throat. Common signs of viral pharyngitis is waking up in the morning with sore throat that gets better throughout the day. They may still hurt, but their sore throat is much worse in the morning. And that will often happen with postnasal drip, okay? So the other thing to look at, if you have a kid who comes in with a sore throat in conjunction with runny nose and congestion and cough, that's not strep, guys, okay? Because strep is not going to present with common upper respiratory viral symptoms. A kid who has strep pharyngitis is going to have different symptoms than a kid who has viral pharyngitis. All right? Strep is characterized by a beefy red sore throat, fever, stomach ache, a lack of runny nose and congestion, unless they have underlying allergies, which is not going to be super common. Okay? So your kids who come in to see you looking very weak, okay, fever, sore throat, some abdominal pain, maybe even some vomiting, but no runny nose and congestion, those are going to be the ones that you would consider are more likely to have your strep pharyngitis. Not the kids that come in with throat pain, myalgia, and arthralgia. Okay, so arthralgia and myalgia, those are two major symptoms of a viral illness. If you have a kid who just comes in like super weak and their muscles hurt and they body ache everywhere and their joints hurt, what does that sound like to you? That sounds like flu, doesn't it? It sounds like influenza. So those signs are more associated with a virus. Sore throat and dysphagia, okay? So pain on swallowing. Yes, that can happen with strep, but not if it's in conjunction with rhinitis and cough and hoarseness. Okay, all of those things are very viral, okay? Now, other things that can be seen in a viral pharyngitis, stridor. All right, when you think about stridor, what do you think about? What's stridor? Stridor is that, and those kids usually have a type of cough. They have a barky, hoarse cough, okay, a croupy, almost seal-like cough. So that is seen in the common disorder that we would call croup, okay? But we'll move on there in just a little bit. So viral pharyngitis exam, just like we said, erythema of the tonsils, reactive cervical adenopathy. They may have swollen lymph nodes, guys. That's common. Virus-specific physical findings include exudate on the tonsils can be present with EBV. Okay, please do not assume just because a child has exudate on their tonsils that they actually have strep. Okay, now, don't get me wrong. If you're seeing a bunch of pus pockets and the kid has no upper respiratory symptoms, then you're going to swab that kid for strep. I understand that. But if you have a bunch of exudate on the tonsils, fever, sore throat, and you swab them for strep and it's negative and you're like, holy moly, why is that? It could be mono. Okay, and that's what the Epstein-Barr virus is mono. And that is a little bit more common in your older kids. Okay, so you're going to see these more in adolescents than you are young children. Adenovirus, okay, it can cause follicles on the pharynx. Enterovirus can produce vesicles and ulcers. If you see blisters and ulcers on the back of the throat, that is a virus, okay? That is going to be viral in nature. Very unlikely would that be bacterial, okay? A bunch of little scattered vesicles and blisters and ulcers, that is a virus, guys, okay? It may be a herpes virus, Coxsackie virus, and all of those, a lot of those viruses are very closely related. Parainfluenza and RSV also cause more lower respiratory tract diseases, okay? So croup, pneumonia, and bronchiolitis. So croup, like I was just saying, can be caused by stridor or can cause stridor, okay? Pneumonia, you may see and hear adventitious lung sounds such as rales, crackles, even wheezes, but a little less common with wheezes than your rales and your decreased breath sounds. Bronchiolitis, very commonly wheezing, okay? And we'll move a little bit on for that. in a bit. Influenza, usually associated with cough, fever, and multiple systemic complaints. So that's what we were talking about up here. That pain, that muscle aches, the body aches, the fever, the sore throat, plus the cough and the runny nose, and everything hurts. That is not strep. Okay, so if they come in with sore throat plus a bunch of other upper respiratory symptoms, you really need to have strep in your differential, but you should really be considering a viral cause more. Okay, so next, bacterial pharyngitis and tonsillitis. Okay, so the most common cause of bacterial pharyngitis in kids is group A beta hemolytic strep. Okay, counts for about 15 to 30% of infections in children with acute sore throat and fever. Okay, and that is just acute sore throat and fever together, okay, without other things present. Group C and Group G streptococci can cause pharyngitis, but they're a lot less common, and antibiotic treatment doesn't prevent, it's only non-suppurative complication, okay, glomerulonephritis. Just because a kid gets treated for strep appropriately does not mean that they cannot suffer glomerulonephritis or kidney disease secondary to GA-BHS. So don't think that just because a kid has gotten glomerulonephritis that it's because their treatment for their strep was bad. It doesn't necessarily mean that, okay? How a kid gets or tolerates a strep infection doesn't necessarily mean that it's because they weren't treated correctly. Okay. So acute onset of sore throat, like I was saying, they're going to have headache. They're going to have nausea and vomiting, abdominal pain, okay, plus fever, okay. Abrupt onset without nasal symptoms. Just like I was saying, we're not going to have runny nose and congestion and cough with this, okay. Constitutional symptoms such as arthralgia, myalgia, and headache are possible, but they're less common. You're going to see moderate to high fever, weakness, prominent sore throat, and difficulty swallowing. Sometimes these kids will tell you their throat hurts so bad it feels like they are swallowing glass. They don't want to eat. They don't want to drink. They want to do nothing. And that's often why we will sometimes see concomitant dehydration in these kids, because their throat hurts so bad that they want to eat and drink nothing. All right. So abdominal discomfort, like we already said, that's listed up here as well. Probably late winter or early spring. Okay, so that's really when we're going to be seeing that occur most commonly. No cough, guys. All right? So it's not common for your kids to come in with a sore throat that have a cough and runny nose and congestion. I'm going to keep saying this over and over again because I see too many times kids are diagnosed with strep pharyngitis because they have a sore throat and they may have even gotten a positive strep because the provider or the nurse has held it up to the light and they think they see the line. Oh, I'm pretty sure it's a faint positive. I love when I hear that from somebody when they say, I'm pretty sure this is a faint positive strep. I think I see the line that's telling me this strep is positive. Nope. A faint positive is probably a forced positive strep, okay? So be smart and be wise about your testing. And if you're really concerned or you're really thinking it's possible, order a culture instead. That is the gold standard, okay? If you have a positive rapid strep antigen, then you certainly will treat, okay? If it's a true positive, it's definitely bright and showing up for you positive, okay? But if you have a negative and you have ordered a rapid strep, okay, this is AAP guidelines, American Academy of Pediatrics. If you have ordered a rapid strep on a patient and you have come to your executive clinical decision that this patient might have group A beta hemolytic strep and that rapid strep test is negative, it is your responsibility to send a culture, okay? The only instance that might not be forced for you to send a culture is if you have ordered, if you have the in-office PCR or DNA strep swabs, because those are pretty accurate. Okay, they're pretty. It's assesses for the presence of DNA and RNA in for the strep bacteria. They're pretty expensive, so most primary care offices do not have them. But really, the end-all be-all, best gold standard treatment for that is if you've ordered strep, the strep is negative, send a culture. Okay, 48 hours later, if you haven't started them on antibiotics, only 48 hours later that grows, strep and you didn't start them on it, that's okay. You call that parent up and you let them know, hey, we're going to get you started on some amoxicillin, because even though he was negative in the office and I did the right thing by not prescribing antibiotics at that time, we now have a positive strep on culture and I'm going to do the right thing right now by prescribing antibiotics, okay? Where you really start to get concerned with a child who's been without antibiotics with strep is around that 8 to 9 day mark. Okay, so take that into consideration also, because that would be where there's a possibility for your rheumatic heart disease and other major sequelae and complications is after that 8 to 9 day mark. Okay, so whenever the kid comes in, if they've had 2 days of symptoms, you've ordered a culture, 2 to 3 days later, your culture comes back, you're only at 5 days, and you've given them antibiotics. Okay, all right, so tonsillopharyngeal exudate that is yellow blood tinged, okay, frequently petechiae on the soft palate, so that's what you see here. Okay, petechiae on the soft palate is pretty sensitive for strep pharyngitis. Okay, swollen and beefy red. Okay, so take a look at these uvula, or I'm sorry, the uvula and these tonsils here. See how they're beefy red and swollen? It's not like the page that we saw here. Okay, see how this is kind of scattered, erythema. You don't see a beefy red appearance. You don't see any petechiae. You just kind of see some injection in the back of the throat there. Totally different than what we see here, right? All right. Tender and enlarged anterior cervical lymph nodes. Okay, so one physical exam distinction between mono and strep pharyngitis. With mono, usually it's your posterior cervical lymph nodes that are tender and enlarged. With strep, usually your anterior cervical lymph nodes are tender and enlarged. So in the back of your cervical chain is where you're going to see your mono cervical nodes enlarged, and in the front, anterior cervical lymph nodes are going to be more enlarged with your strep pharyngitis. It's just one thing for you to be thinking about when you do physical exams. All right, so bad breath. Parents will tell you that too. They'll be like, her breath stinks. It smells weird. Or sometimes parents will tell me she has that sick breath. She has that sick stink mouth. And that's because usually caregivers can recognize when a child is sick based on the smell of their breath, if they have a funky, sick smell to their breath. Parents are good at that. All right. So a stigmata of scarlet fever that may be seen. A scarlatiniform rash. Okay. A strawberry tongue and circumoral pallor. Okay. A scarlatina rash is typically starts out on the chest and the thorax. It kind of feels sandpapery. It's pinkish red. Strawberry tongue means exactly that. It looks like a giant strawberry in their tongue. It looks like they open their mouth and there's a strawberry right there. You can see all the little tiny papillae in the tongue are more white and the whole tongue is red. All right. So treatment for GABHS. I'm going to say this over and over again until I say this too many times. Penicillin, amoxicillin. Okay? Penicillin, amoxicillin. How do we treat strep, guys? Penicillin, amoxicillin. Penicillin, amoxicillin. I know you're getting annoyed at it, but I can't tell you how many times I see providers prescribe things that don't need to be prescribed for strep. We can still safely treat strep with penicillin VK and amoxicillin. Now, I will tell you, in children, it is sometimes very hard to get them to tolerate this penicillin because it is not palatable. It tastes awful, okay? So, you know, don't be surprised if you're prescribing more amoxicillin than penicillin, just because it's common for kids not to be able to tolerate this penicillin VK because it just does not taste good. No matter how much you mix it with, I've tried every flavor with a pharmacist, and it's not always palatable. Sometimes your older kids can tolerate it, but amoxicillin and penicillin are going to be your treatments for strep pharyngitis, okay? Now, if they are allergic to penicillin, there are things for you to consider, okay? How allergic are they? All right, what is the type of allergy they have? If they have type 1 hypersensitivity to amoxicillin, okay, so that's like I'm going to go into anaphylactic shock and I'm going to be like pretty badly allergic to type of amoxicillin or penicillin. I'm going to have some angioedema, may have some abdominal and facial swelling. You are not going to give a cephalosporin, okay, because cephalosporins are cousins of penicillin, And there's a 10% chance of cross-reactivity of allergy in children who are allergic to amoxicillin and children who receive something like Omnicef, which is Ceftonir, or Cephalexin, which is Keflix, or Cefixime, which is Suprax. Okay, you need to know those things. If they have no allergies to, or not a type 1 hypersensitivity, but they get a rash and it's not associated with angioedema, but they might have some hives, and they've tolerated other cephalosporins in the past, then it's perfectly fine for you to make the good and prudent decision for them to have either a cephalexin or cefredoxil, something like that, or Ceftonir, etc. Now, these other options, okay, it's going to be so imperative for you to learn what antibiotics are in what class. And it's not easy to remember. Shoot, guys, I don't even know and remember every class of antibiotics. And you know what? That's why I have a really good antibiotic guide, okay? I have an excellent guide that tells me what types of infections are treated by what types of antibiotics, and it lists it in beautiful tables for me. You must have that as a provider unless you are a stellar pharmacist mind, okay? Now, you'll learn the major antibiotics in the classes, but you need to have a good understanding of what class of antibiotics treat what kind of infections. Okay, so azithromycin, that's going to be a macrolide. Sorry, same thing with your clarithromycin. Okay, it does treat strep pharyngitis, but some people do not know that there is a strep dose for azithromycin. It is not the same type of dose that treats certain less complex upper and lower respiratory infections. So your upper and lower respiratory infections can sometimes be treated with a 10 milligram per kilogram per day on day 1 and a 5 milligram per kilogram on days 2 through 5, 5 total days of azithromycin. You cannot do that for strep. Strep dose of azithromycin is 12 mg per kg per day for 5 days. Okay? All right, let's move on here. Pertussis. Pertussis, I would love to say, is eradicated the way it used to be, but unfortunately, because we are seeing such a high rate of vaccine hesitancy, vaccine refusals, there are pockets of the country and other countries that we're seeing rising cases of pertussis and things like measles, mumps, and even rubella, and other infections like Hib. These super easy to prevent diseases are coming back because we are not vaccinating our children. So you have a major responsibility as a provider to not only treat these vaccine preventable diseases, but also to educate on the prevention of these diseases. And the number one, as I've said in other videos before, the number one way and number one source of prevention in pediatrics is vaccines. Okay, immunizations save lives. So please do your part to educate, provide evidence, make parents responsible and have them understand and take responsibility for their decisions, and utilize a vaccine refusal form so they know and have to sign away at what they are doing. Okay? Anyway, so pertussis, caused by gram-negative bacillus. Okay, Bordetella pertussis is the actual bacteria that causes pertussis. So one of the common things you're going to see in children who have pertussis is a whooping type of a cough. It's an inspiratory whoop, kind of like a type of a cough, and it happens pretty quickly with their cough, okay? And it's a horribly sad sounding cough, and it's a very uncomfortable type of cough. These infants will often have poor feeding. They'll have tachypnea. Okay, they'll have apnea if they're infants. Okay, sometimes associated with seizures, and they're caused by hypoxemia. Older kids usually they'll have the same types of whoop with their cough, okay? But older kids will also manifest with really severe conjunctival and subconjunctival hemorrhages, okay? Their eyes are going to look like they are bleeding from the inside out, and you're going to look at them and go, oh my gosh, that must be so painful, but you know it's actually not painful at all. It's not painful whatsoever. So let me see if I can bring a picture up of it. There's lots of good pictures online with that. Here it is. Here's a good one. This is the one that the CDC uses. I'm going to move this over to the... Give me just a second here, guys. Okay. So this is what your subconjunctival and conjunctival hemorrhages look like. This poor baby has coughed so hard that he has literally burst the capillaries in his eyes and up underneath his eyes. Okay, so the only other thing, if this kid didn't come in with a cough, the only other thing that you might be thinking about here, obviously, is some form of severe platelet or anemia, or even a skull fracture that's causing that raccoon-type eyes. But this is a child who has pertussis, who has had a severe cough for a couple of weeks, and it's just led him to just burst all of these blood vessels in under his eyes and around his orbits. Okay. So, diagnostics. The gold standard is for you to do a culture, okay? A PCR is very sensitive, but it's really not FDA approved. So, if you really think a child has pertussis, you're going to be starting them on treatment, and then you're going to do the pertussis culture, okay? And that's just a swab. Best time to test is after the illness has been present for at least 2 weeks. But it's easy to see why many providers would refrain from not giving treatment for this long, okay? So, basically, what I'm saying is, if you have a child who comes in with a whooping cough, we're not going to tell you to tell the kid to go home and come back when their cough has been present for 2 weeks, especially if they're an infant. My goodness, we wouldn't do that. You can do a culture, and you can treat, and if the culture does not come back positive, but the child comes back symptom-free after you have prescribed treatment, then you can pretty much assume that your clinical diagnosis and your empirical treatment was appropriate. Let's see here now. Wait a minute. So how do you treat pertussis? What is the best form of treatment for pertussis? The answer to that is going to be a macrolide. Okay, it's going to be erythromycin. Okay, azithromycin if you can't give erythromycin. Little tiny babies have to have erythromycin. Not always the greatest to give Zithromax unless that baby is at least 6 months old. I have seen it given when they're monitored, but most Lexicon, Perriott Lane, most pharmacopoeias or recommendations by like Up to Date and AAP will ask you to wait until they're a little bit older to give that Zithromax. And it's not because there's major unsafe documentation or evidence for Zithromax, but what happens a lot in kids, why we can't give certain medications, has nothing to do with there being unsafe, has more to do with there being a lack of evidence and randomized controlled trial and research in children that young with that medication. So if you're seeing something like, you know, don't give this medication until 1 year, it doesn't always necessarily mean that it's unsafe. My gosh, a large percentage of the medications that we give in pediatrics are off-label. And shoot, in the NICU, 98% of them we give are off-label. So it doesn't necessarily mean it's unsafe to give. It just means that it is something that is not FDA approved or recommended, mainly, usually because there's a lack of research to support its use. Okay. Moving on. Nasal foreign body. Let me just tell you, I have never smelt something so bad as a child who has a nasal foreign body. It is a really, really horrible smell, okay? So that is the classic symptom of a nasal foreign body in a kid, is a unilateral, purulent, foul-smelling nasal discharge. I don't know if you guys have ever seen that movie Total Recall, but this picture cracked me up. That's why I have that in there. But anyway, whoops. So if the foreign body is embedded in granulation tissue or mucosa, it may take on the appearance of a nasal mass. Other symptoms obviously include mouth breathing, some nasal blood or epistaxis, and then nasal obstruction. You may hear the parents say, my gosh, they're just so congested, but they don't have runny nose on this side of their nose, and they don't have a cough or anything, okay? Now, the treatment of a nasal foreign body, it's not going to be antibiotics, okay? It just needs to come out. The nasal body needs to come out of the nose, okay? And removal will depend on its location, its composition, and the skill of the practitioner. I use alligator forceps to remove things. suction with narrow tips, cotton tip applicators, okay? The best way, if you've got a parent that calls you and says, you know, I think my son has something in his nose and I don't know if it can come out, tell them over the phone to do kind of what's the kiss blowing technique. You're going to have them hold the other side of the nose, and you're going to have them blow in the child's mouth. And sometimes it'll just pop right out of the nose, and that can be helpful. Other techniques include like a little hook curette or to roll the object out. A 5 French catheter with a balloon can be advanced. And there are some really new cool tools out there, but they are expensive. Okay, so little tools that you would insert up the nose, inflate the balloon, and then pull back out, and it pulls out the foreign body. But these things are really not cost effective. So if you just look and you know, I can't get that out, it's too far up, or you've tried and you can't get it out, or the kid's not being, cooperative, or the parent's having a difficult time, an ENT referral is the next best step. Okay. You have to remember that the foreign body can be forced deeper if you're inexperienced and you don't know what you're doing. So if you look into the nose and it's not something you feel comfortable doing, you may be able to consult with a different provider in the office to help you get it out. But if that's not a good option, then the other option would be just to refer to an ENT. Okay. So extrathoracic disorders. So extrathoracic disorders include things like acute laryngotracheitis, epiglottitis, laryngotracheobronchitis, diphtheria, and foreign bodies, which we already talked about. Okay. Now, laryngotracheobronchitis is basically croup. Okay, so I'm sure we talked a little bit about croup already, but let's talk a little bit more about it because it's pretty common in kids to get croup secondary to a virus. Croup is almost always a virus. Okay, I don't think I've ever diagnosed croup in a child who had a bacterial infection, to be perfectly honest. And croup usually stems from a parainfluenza, RSV virus, or other common, coronaviruses. Kids are just super sensitive and susceptible because their respiratory symptoms are so small. They're susceptible to croup. And the way that you're going to see croup in a kid is they're going to come in with, runny nose, congestion, high fever sometimes really like high. I've seen croup present with 103, 104 fever with that very barky and seal sound that I was talking about before. Okay. Now, epiglottitis, scary. We don't see that very often. Okay. And it's because a lot of those diseases that cause epiglottitis are secondary to diseases that we are treating well with vaccines. So, but epiglottitis can manifest with a kind of a tripod position, marked respiratory distress. Okay, marked respiratory distress. And diphtheria is something obviously we vaccinate for, so it's not something that you'll commonly see, but if you do see kind of a membranous nasopharyngitis, obstructive local infection, kind of a gray membrane that exists over the back of the throat, that is commonly seen in diphtheria. Okay, so as we were just talking about croup, treatment of croup depends on the severity, okay? You must educate the parent, okay? A frequent croupy cough, audible stridor, suprasternal and sternal retractions at rest and no agitation, that would be a moderate presentation. Occasional croupy cough, no retractions and no chest wall tractions, that is going to be a mild presentation, okay? A severe presentation is going to be a frequent croupy cough, tachypnea, prominent stridor, agitation, and distress. And that stridor is usually at rest. And then respiratory failure impending is going to be stridal, retractions, lethargy, decreased level of consciousness, and dusky color. I am going to tell you very rarely have I ever seen these two in primary care. Now, I am a pediatric nurse by trade, and I have worked in the emergency room and the ICU, so I've certainly seen these in the hospital, okay, that needed hospitalization and monitoring and intensive care. But in primary care, they're usually seeing me at this mild to moderate, okay? Now, Treatment for croup. You can give oral steroids if they are at that moderate level. If you've only got a child who has mild croup, they probably don't need an oral steroid, okay, or an injected steroid. But there's lots of evidence to suggest an injectable steroid is very helpful for kids who have croup because they don't have to swallow it, and it lasts for about 72 hours, okay? So I'm talking about like a dexamethasone, and that dose would be anywhere from like 0.3 to 0.6 mg per kg for a one-time dose. But I will also tell you that many primary care offices don't carry injectable dexamethasone or Decadron. So it's not necessarily something you'll have access to. You can certainly also prescribe oral prednisolone, okay? Prednisolone is a steroid that we use often in young children if they need it, okay? And the dose for oral prednisolone in a child who has croup is 1 to 2 milligrams per kilogram per day, and you would divide that usually in 2 doses. They may only need 1 dose per day for 3 days, but you're not usually going to go above that 3-day mark for your steroids. Now, I hear often a lot of providers and students will be like, no, you can't give steroids unless you bring them down on a taper. Guys, not if you're only doing 3 days, okay? If you're doing 3 days of steroids, you can feel pretty comfortable, and there's some really good evidence, and so does, and Up to Date even says this as well. If you're only going to do 3 days of steroids, you're probably okay not to do a taper. Now, if you're having to do 7 to 10 days of steroids for some significant illness, then yes, in order to prevent a, adrenal crisis, you definitely want to consider tapering that steroid dosing, okay? But for croup and a couple days, you don't need to do tapering of your steroid. Okay, so epiglottitis, I'm not going to spend a lot of time on this because it's really something that we don't see much anymore. However, it's something you must know how to recognize because it's one of those red flag diagnoses, okay? Muffled voice is what aphonia is, drooling and high fever, and then this tripod position here. It's very common in a child who has epiglottitis. From the time that symptoms start, okay, the time from the onset of symptoms until death may be a matter of hours. That is the part that is scary, okay? So this is what a normal larynx looks like, okay, going down into your respiratory system. This is what epiglottitis looks like. You can see why a child would not be able to breathe, right? Okay, so this kid is intubated. You can see the endotracheal tube here. But this is serious enough that I want you to make sure you understand what the symptoms are because it progresses so rapidly. You have hours until the time of complete airway obstruction and possible death, okay? Nasal flaring. All of these types of retractions, all kinds of retractions are often present. The child assumes a position of hyperextension in the neck because that is how they breathe better, okay? Their tongue may be hanging out. The parent may say that they were complaining of sore throat earlier that day, stridor and irritability and restlessness and brassy cough, okay? Brassy cough is kind of uncommon, but again, airway obstruction follows within 2 to 24 hours, so you must recognize and diagnose this quickly. It is not something you will manage in primary care. It is something, boop, boop, goodbye, hello, out the door with EMS to the emergency room. Okay, bronchiolitis. This is a very common condition in pediatric patients, okay? Diagnosis of bronchiolitis is reserved for children 2 years and under. It is not the same thing as bronchitis. Okay, that is essential because I see people who diagnose bronchitis in a 1-month-old and bronchiolitis in a 6-year-old. But in order for you to understand why these conditions are present in the ages that they are, you must kind of have an idea, just like we said before, about how pathophysiology and anatomy and physiology work. Okay, so in a young baby, okay, so anywhere from 0 months old on up to 2 years, so neonate up to 2 years, a toddler. Upper respiratory infections or colds or certain viruses affect the small airways of the lungs in these children, okay? That they're called the bronchioles, okay? They're tiny airways, and that's what is most affected in a child under and at the age of 2. That is why they are more likely to get bronchiolitis, okay? In children over 2, okay, they are more likely to get inflammation of the bronchus, okay, so and bronchial trees that are larger, so bronchitis. All right. Now, that doesn't mean that you're not going to see wheezing in a child who's over 2 years old, because certainly other conditions cause wheezing. But a child who has bronchiolitis, this disease causes inflammation, necrosis, and edema of the respiratory epithelial cells, okay, the lining of those small airways, and lots of mucus production. Okay, so when you have an inflamed bronchiole, and then it's also got lots of mucus sitting inside that bronchiole, and they normally look like that, what do you think that child's breathing is going to look like? Whew. They're going to breathe hard. They're going to have retractions, maybe subcostal, maybe intercostal. They may have some tracheal pulling if they're in severe respiratory distress and needing to go to the hospital, okay? They may have suprasternal retractions up here. And it's important for you to know how much distress they are in, because kids with bronchiolitis, especially if they are infants, can decompensate very, very quickly. Think about if you have necrosis of the small airways of your lung. And now this is usually in small or severe cases of children with bronchiolitis. But if you have necrosis of certain epithelial cells in your lungs because you've had a lack of perfusion and so much obstruction and inflammation, you're going to have a major difficulty breathing, okay? What these parents will often complain of is cough, okay, rhinorrhea, congestion, coryza symptoms, sometimes fever. Most of the time, I don't see a super high fever with bronchiolitis, usually up to 101, but it is and can be associated with a higher fever and only be a virus. But if you're seeing a high fever in a child with these symptoms, you really do want to make sure you're doing an excellent physical exam to rule out pneumonia. All right, so how are you going to treat bronchiolitis? We've talked a little bit about the physical exam, so they're going to have upper respiratory symptoms. They may have, some red eyes, watery eyes. It's not going to be bacterial eyes. It's just going to be watery and viral looking eyes. Possibly some pharyngitis in the back of those young kiddos' throats. You can see an otitis media, but this is likely going to be a viral otitis media, okay? If I have a kid who has a really bad bronchiolitis infection and a little red ear, I'm not going to give them antibiotics right away. I may see them in a couple days and see if that ear looks okay, because it's not necessarily going to be from a bacterial infection, okay? Lower respiratory findings, you're going to see tachypnea. You're going to see retractions, okay? If they are wheezing, you're most often going to have tachypnea and retractions, okay? Expiratory wheezing. That is something that you're going to see often in bronchiolitis, okay? When you have a child who has inspiratory wheezing, that is more associated with bronchitis, and a bronchitis does not occur, again, in what age? It's not going to occur in your kids less than 2 years old. Okay, not unless it's associated with a laryngeotracheobronchitis, which is the croup infections. Okay, all right, and then various signs of respiratory distress. Obviously, you have a kid who's grunting with contractions and cyanosis. Out the door that kid goes, on EMS to the emergency room, because you cannot provide care in primary care for a child who needs that emergency care. Abdominal distension is possible. Okay. A lot of times these kids will have hyperinflated lungs, so their liver and their spleen will be pushed down some. Do not prescribe nebulizers or any kind of bronchodilators for kids who have bronchiolitis. It's not necessary. There have been new evidence and research findings that bronchodilators, like your albuterol and your Xopenex, do not do anything for bronchiolitis. Okay, we used to give a little trial of Xopenex or albuterol to see if they were what was called a responder, but we don't do that anymore. We just don't give it. Now, there's exceptions to that. If you have a child who is considered to be atopic, okay, So they've got as eczema, and they've come in and they've been seen for wheezing 3 or 4 times. And now they also have a cold, and it's probably some bronchiolitis. That one you can probably get away with treating with a bronchodilator because there's possibility that they have reactive airways and asthma. Okay, don't be afraid to diagnose asthma in primary care. If you can't and you need to refer to a pulmonologist or an asthma and allergy specialist, that's okay. But if you have a kid who has atopic conditions like allergic rhinitis or food allergies and also eczema, and they're frequently wheezing, that's probably a reactive airways or an asthma, okay? So those kids who come in with a bronchiolitis because they've got a cold and it's gone down to their lungs, those kids you can give bronchodilators because they will need it not just for their bronchiolitis, they will need it for their inflammation secondary to the bronchoconstriction from their reactive airways. Does that make sense? All right, so treatment. You're going to give, lots of suction. Suction, suction, suction. I can't say that enough. Kids who have bronchiolitis have copious nasal secretions. They need to be suctioned, and that often can make a difference in their oxygen saturation. I've seen kids not suction, and I suction them out, and they go from an 89% oxygen saturation to a 96 just from suction. Okay? So, you're going to give cool mist humidifiers at the bedside. There's no place for antibiotics in the treatment of bronchiolitis. Okay? Unless you think there is the presence of a bacterial infection as well, but that's not common. Most infants with mild signs of respiratory distress can be treated as outpatient if their oxygen saturation is normal. Okay? There is also some evidence to suggest that administration of nebulized hypertonic saline can be used while hospitalized, but it's really not something that you would use in primary care. Okay? So follow-up, suction, cool mist humidifier, no meds. We're not going to be giving Benadryl to these kids. We're not going to be giving, Zyrtec to help dry up their nasal secretions. We're not going to be telling mom to go ahead and put them to sleep with a little bit of whiskey on their gums. They need no meds. They need oxygen. They need a nice clean room. They need a cool mist humidifier. They need lots of suction, and they need patience and supportive care. And this sometimes is very frustrating for caregivers. It's scary and frustrating for parents. So don't be surprised if they look at you like, oh my gosh, my kid is so sick. What are you actually doing for them? Talk to them very passively and from a perspective of evidence. That's all you have to do. Bring in your own personal stories if you can. I have a child who has had this, and I know how scary it is. But I promise you that evidence says they will be treated and heal better with A, B, C, D, and E. Okay, so moving along. Acute bronchitis. So this is what I was talking to you about. This is something that can be diagnosed over 2 years. It is not diagnosed under 2 years, okay? So the usual course is divided into 3 phases. So we have a phase where the upper respiratory symptoms predominate. Almost 99% of acute bronchitis infections stem from an acute upper respiratory infection. So what that means is they started out with some congestion and runny nose and a cold. And I'm sure all of you are sitting there going, oh yeah, I have totally gotten a cough or a cold before that ended up in this really harsh, deep bronchitic cough and infection. That's because most acute bronchitis infections actually stem from a viral upper respiratory infections, okay? These kids usually end up with a dry, hacking cough for several days. It sounds deep and it sounds chesty. I know that's kind of a weird way to explain it. It's super non-technical. I'm saying this really as a mom and as a provider of kids for so many years. When I say chesty, I mean it is a deep cough that comes from the chest, okay? And looking at the inside of these lung trees, you can tell that it's probably going to be productive because it's got lots of mucus there, okay? The bronchus is inflamed, okay? These bronchial trees are inflamed and they have got lots of mucus in them. They may have chest pain, okay? A lot of kids who come in with a cough and they say their chest hurts, you should immediately have bronchitis and pneumonia on your differential list because a cough with chest pain can be from swelling and inflammation in the chest. Bronchitis can also present with inspiratory wheezing. Okay, so when you have a kid who has wheezing from bronchitis, it's usually on inspiration. And that's a good way for you to kind of assess the differences between maybe an asthma type of a wheezing. Okay, so reactive airways or asthma usually has end expiratory wheezing. If you've got inspiratory and expiratory wheezing in a child who has asthma, that is a medical emergency, and they are probably in severe respiratory distress. But anyway, so think when you're hearing inspiratory wheezing, think bronchitis if they've got the other symptoms to also be present with that. Family history of asthma, CF, atopic infections are also common, okay? Tobacco smoke exposure in kids who have recurrent bronchitis, I will often see that their families, caregivers, parents, or people close to them smoke a lot and also smoke in the house. So remember that education on smoking cessation, or at least not smoking around your children, is essential. Okay, so you're going to see variable rhinitis, okay, low grade or no fever, signs of nasopharyngeal infection, maybe conjunctivitis, coarse breath sounds. So when I say coarse, that really just kind of means rough. So kind of like a roncorous sounds or coarse breath sounds are common, okay? Possibly some rails, okay, but rails or crackles in my practice and in my experience have really been more associated with pneumonia than bronchitis, okay? So if you're hearing rails, especially isolated rails, okay, not rails throughout, but isolated rails would be more associated with pneumonia. And your rhonchi, your coarse lung sounds, and inspiratory stridor is, inspiratory wheezing is more associated with bronchitis. Now, how do you treat it? Okay, for acute bronchitis, the specific therapy is nothing. You're not going to give them antibiotics. Okay, bronchitis can be treated supportively. Okay, care is supportive. Sometimes people look at me and they go, "What? My doctor always gives me a Z-Pak for bronchitis." Well, that used to be the way that we treated bronchitis, but it's not anymore. We know a lot more about bronchitis. We know that most of the time it stems from a viral infection. Now, there are a couple exceptions to this rule. Okay, if you think that the child may have like a protracted or a bacterial-based bronchitis, okay, that's usually present for like longer than 3 to 4 weeks, or if the child has concomitant asthma and is susceptible to bronchitic infections because of the mucus production in their lungs that is constant, then you may consider giving them some antibiotic management, possibly with, a macrolide antibiotic, because that treats lung infections very well. All right, so you're going to use analgesia for pain. You want to tell them you're going to use some Tylenol, you're going to use some Motrin if it's age appropriate for that child. Lots of fluids, okay? Intake of fluids also helps to thin mucus, and that's important. A cough with bronchitis can last several days. In fact, sometimes up to 10 to 14 days, okay? And then after that 10th day mark, it starts to get a little bit better. If influenza is the cause of the bronchitis, and that is possible, then you can certainly give that child some Tamiflu, okay? Most cases of acute bronchitis, like we said, are from viral sources, so antibiotics are not indicated, okay? But if you suspect mycoplasma, okay, then you can give a macrolide antibiotic as well. Now, mycoplasma pneumonia is usually it's walking pneumonia, and it's usually asymptomatic in the lungs. Like, you're not going to hear a whole lot in the lungs. Maybe you'll hear some decreased lung sounds, but more often than not, they're just going to have this really yucky cough that's there, and it doesn't go away, but they have normal lung sounds. In other cases of mycoplasma pneumonia, you may see scattered rales or crackles all throughout the lungs, okay? If you have rales everywhere in the lungs and you have a child with a cough and they're a school-age child, then you can probably assume that they've got walking pneumonia or mycoplasma pneumonia, and you would give them a macrolide for treatment for that. And macrolide is going to be either your erythromycin or your azithromycin. No cough suppressants. There's no evidence to suggest that these kids need that. In fact, we want them to cough. See, I'm coughing just talking about it. But Giving them cough suppressants really is not going to help them any, nor is antihistamines. And your parents are going to beg you sometimes. They're going to be like, oh my gosh, she is keeping everybody in the house up. If the child is truly uncomfortable, they're not able to get any sleep, and they are having so much coughing that they are not able to eat well and they're dehydrating, then you can certainly consider giving some cough suppressants, okay, over the counter. But it's not something that is first-line therapy. And bronchodilators, no evidence to support the use of bronchodilators, okay? Unless there's obstructive wheezing from other sources of illness, such as reactive airways or asthma associated with that. Now, if the child has chronic bronchitis, treatment does depend on underlying cause. But if you're thinking a child has chronic or recurrent bronchitis, they really should be referred to a pulmonologist. Okay, so pneumonia. This is one that I usually find students will be either really scared about or confused about, because we have viral pneumonia and we have bacterial pneumonia. Well, which one how do I know? And it's really important to know that, because one, I need to give an antibiotic, and one I don't, right? What we know is that pneumonia is a lung infection that affects the air sacs. Okay, this is the alveoli of the lungs. And the infection interferes with the delivery of oxygen. And that is why children, the most sensitive symptom of children with pneumonia, or adolescents or school age and preschool kids with pneumonia, is going to be tachypnea. Okay, so sensitive sign of pneumonia, remember, tachypnea. That is the most sensitive sign. Okay, what are the symptoms? Cough, rapid breathing is the tachypnea, like we said, difficulty breathing, grunting, chest retractions, nasal flaring, and then in older kids, like we were talking about earlier, they may have chest pain or even shortness of breath. Now, you're thinking, oh my gosh, Dr. Bice, those are all the same symptoms that you just told me about with bronchiolitis and even maybe bronchitis. It's not the same. There's going to be other things that you will be able to recognize, okay? So let's take a look at bacterial pneumonia. You will be able to and must understand that certain age groups, okay, and certain other symptoms in those age groups will depend on a diagnosis, okay? So mycoplasma pneumonia occurs a lot more frequently in children who are older than 5 years old. If you have a kid who comes in with severe respiratory distress, coughing, fever of 101, and they're 3 months old, they're probably not going to have mycoplasma. Okay, not unless they've been exposed to with other kids who have mycoplasma. So anyway, it's something that you need to consider with age, okay? So onset is acute and gradual. For mycoplasma, the onset is slow. So these kids have usually been sick for a few weeks. Sometimes they're coming with 10 to 14 days of cough and they're just not feeling better, etc. Now, I did put a note here that I actually disagree with the greater than 102 fever for mycoplasma. Typically, it's associated with a lower grade fever, and I did find that reference for you and up to date. So you will not be tested on something that tells you about the fever with mycoplasma. Again, mycoplasma pneumonia is usually present with a lower onset of fever, not higher. Even though your Burns text does put greater than 102. I think that probably honestly was a typo. Okay, so next, clinical findings. Usually starts with a cold. Presents, okay, with bacterial dyspnea, tachypnea, rales, decreased breath sounds, grunting, retractions. These kids look toxic. They do not look okay to walk around. They do not look okay to eat. They do not look like it's okay for you to not manage them with close follow-up. Okay, these kids are really sickly looking. Okay, and potential progression to severe respiratory distress. That's what a bacterial pneumonia does. Now, viral pneumonia, you may see cough, coryza, hoarse, crackles, wheezing, and stridor. A lot of times, kids will have secondary viral pneumonia from their bronchiolitis, okay, or from another viral infection. And in my experience, the presence of crackles and wheezes together is almost always associated with a viral infection. Okay, so if you have a kid who's got scattered wheezes everywhere and also scattered crackles everywhere, they're most likely going to be younger babies, because that is more commonly seen with infection and inflammation of the bronchioles and then also the alveoli. But Usually when you have wheezing and rales or crackles together, that's usually a virus, okay? So fever, greater than 102.2. These kids have high fever. When they come in to see you and these other bacterial symptoms, they're going to have high fever, okay? You're not going to see a kid with severe bacterial pneumonia who has a fever of 100.0. That just doesn't happen. I will tell you that pneumonia is a clinical diagnosis. You do not need to do a bunch of x-rays and blood work to verify your diagnosis. You can diagnose that clinically on a physical exam and a history. I'm not saying you have to. You certainly can refer the child for a chest x-ray to verify that they have pneumonia if you need to. And you can do a CBC if you feel like that will help you in your clinical decision making. But it's not required. Okay, remember, pneumonia can be diagnosed on physical exam in your office with just a physical exam and your history. Okay, so get good at physical exams because your diagnosis, differential, and your management can be done with a good physical exam and history in many cases. Okay, so lobar consolidation is what you would probably see on a chest x-ray. So what that really indicates in your physical exam is an isolated or lobar consolidation of adventitious sounds also. Okay, so if you have a kid who comes in and has cough, congestion, high fever, runny nose, tachypnea, and isolated crackles in the left upper lobe, that's most likely bacterial, guys. Okay, because if you have a viral pneumonia, they're going to be transient. They're going to be all over the place. They're probably going to be scattered rales like we were talking about with wheezing and rales together, all right? They're not going to be found in one place in your lungs. So if you find that this kid is in respiratory distress, you've got decreased lung sounds in the bases, and you've got a isolated area in the posterior left upper lobe of a bunch of crackles, but not in any other area, you need to be thinking bacterial, okay? Because consolidated lobar crackles are going to be on your physical exam as an isolated set of crackles. So, and then, you know, what you would see in your chest x-ray for viral is just going to be infiltrates kind of transiently located all over the place. Whereas your infiltrate in a bacterial pneumonia on chest x-ray is going to be found in one specific area. Okay, so as far as treatment goes, that depends on the bacteria and the age of the child. But I will tell you that amoxicillin is still an excellent treatment for community-acquired pneumonia. And if it is mycoplasma pneumonia, azithromycin, erythromycin, or clarithromycin. It's usually azithromycin and erythromycin, depending on how old the child is. Clarithromycin, unfortunately, kind of gets a bad rap for kids because you have to give it for so long. It's like a 10-day treatment twice a day, and kids just don't tolerate it. And a lot of times parents call me back and say, oh my gosh, is there anything else we can give? Because this tastes horrible. It gives an awful stomach ache, which most of those macrolide antibiotics do, and you have to take it for 10 days. So anyway, chlamydia pneumonia. I'm not going to spend a whole lot of time on this, but I want to make sure I point it out. Chlamydia pneumonia, you're going to see in a neonate, okay? 2 to 19 weeks old, typically 1 to 3 months old, and that's where they're getting that is from a vaginal birth of a mother who is infected is usually the cause, okay? Tachypnea, staccato cough, crackles, wheezing. Little young kids who present with symptoms like this, you definitely want to think about chlamydia pneumonia, okay? Same type of treatment as erythromycin. A lot of times if you've caught it early that you can treat that outpatient, okay? But if you haven't caught it early and the child is showing any signs of major respiratory distress, you need to refer them for admission to the hospital. Okay. Let's go ahead and move on. All right. So age for common pneumonia pathogens. We did go over this just a little bit, but neonatal, group B strep. Okay, so group B strep. Where are we going to see group B strep in a neonatal? Why would we think group B strep in a neonatal pneumonia infection? Because of mom, right? So group B strep is actually a bacteria that's found in many women vagina, and it's not something that hurts them. Okay, so it's kind of like normal flora to them, but to a baby who is delivered vaginally, it can certainly cause problems. It can cause group B strep sepsis, it can cause group B strep pneumonia, and other problems. So that's why women are tested for group B strep at their delivery. Chlamydia, again, as we already talked about, uncommon. Strep pneumonia, okay, and group D strep, okay. Strep pneumonia gets more common as the kids get just a little bit older, okay. So most common causes of viral pneumonia in infants are going to be RSV, okay, respiratory syncytial virus. RSV is commonly the causer of bronchiolitis. However, I don't call RSV bronchiolitis because we know there are so many forms of bronchiolitis caused by so many bacteria, so many viruses, that bronchiolitis is really, it's caused by a virus, and about 75% of the time it's caused by RSV, but there are other viruses like we see here that cause it. So we need to be very careful about calling it RSV bronchiolitis, instead just calling it bronchiolitis. All right. So influenza, adenovirus, metapneumovirus, also common in infants. Less common, okay, bacterial organisms can cause pneumonia, strep pneumoniae, Hib, okay, Haemophilus, Hib is the actual vaccine, but Haemophilus influenzae, Mycoplasma, we talked about how that's less common in infants. Bordetella pertussis, also less common. Okay, school age, okay, bacterial organisms, strep pneumonia, Haemophilus, tuberculosis, also very, very uncommon, okay, chlamydial pneumonia. And then viruses are going to be the same here for the infants and the preschool age children, except that we would add this bocavirus, which is not very clear in the literature, actually. Okay, school age children, respiratory viruses as listed above, so all of these same ones, and then also the same ones here listed for your bacterial organisms. Now, guys, why is that important for you to know? It's important because this depends on what treatment you prescribe. If they have a bacterial organism, you need to know what antibiotic treats these. And if you don't know what group of antibiotic best treats these, then you're not going to be able to give that child the correct antibiotic. So please get yourself an excellent antibiotic and microbial resource in order to help that, okay? I have an excellent one that I use. It's called the Sanford Guide, and I've used it for so long, and it's a wonderful guide that tells you how often this will treat this, what the percentage of efficiency and effectiveness is, which antibiotic kills which bacteria. It's wonderful. You must have one of those. All right. So clinical manifestations in CF. I'm not going to go over too much detail for cystic fibrosis because by the time we are seeing cystic fibrosis, the wonderful thing about recognition of cystic fibrosis is that CF is now found on state screenings for neonates. So unless you have a child who the parent is refusing the state screen, okay, people used to call this the PKU. It's no longer called that because we test for a lot more than the PKU. It's now called the newborn state screen. And the reason it is called the newborn state screening is because every state puts different conditions in their screening based on regional and common conditions. Okay, a lot of them are the same, and phenylketonuria is definitely in there. But we assess for cystic fibrosis, we assess for sickle cell, we assess for galactosemia and other conditions in that newborn state screen. So it's very uncommon that you will be diagnosing cystic fibrosis, okay? I've done it once in my practice over the last 15 years. And that was just because the kid had a very, very poor service to his health in the first 10 years of his life. And by the time he came to me, he had had pneumonia like 27 times, and he never went to the doctor, and he didn't have good prenatal care. And, you know, by the time I sent him to the pulmonologist and got ordered a sweat chloride test, he was very, very sick. So anyways, what I'm trying to get at is it's not something that you will be doing commonly in your practice. I do want you to know and understand these common conditions and these common symptoms and clinical manifestations, but you must always understand the most important thing about the prevention or the recognition of this, not prevention, but recognition, is the newborn state screening. Okay, so you are all done. And in the words of our dear friend Elsa, let it go, let it go. Don't worry how scary this is anymore. I know I'm a big dork, but I will tell you that the cardiac and respiratory disorders are one of the most common and the most in-depth disorders for kids. So these videos can get quite long. And I will see you for the next video of pediatric disorders.